HHS is now in the room, setting the rules for clinical AI. And the tools your health system already deployed may not survive the scrutiny. My guest is Professor Elizabeth Harris, clinical research and validation expert, and she's going to ask the question most hospital leaders are quietly dreading. Do you actually have the evidence to back up what you've already built? Stay with us. Welcome to Agents of Health. Here is the one thing that changed this week. HHS has moved from watching clinical AI to actively convening experts to write the standards that will govern it. That shift from observer to rule setter is the inflection point. I'm Dr. Wellis, and today we're going to work through what this actually means, clinically, operationally, and for the decisions sitting on your desk right now. My guest is Professor Elizabeth Harris, a clinical research and validation expert who has spent her career asking whether the evidence behind health technology is as strong as the vendors and the press releases claim. Professor Harris, welcome.
Thank you. I'll warn your listeners now. I'm probably going to slow things down a few times.
That's exactly why you're here. Let's start with the signal. HHS convening experts to write clinical AI standards, plain version. What happened and why does it matter?
So HHS has stood up a process, clinical experts, technologists, policy people, with the explicit goal of producing standards for how clinical AI should be developed, validated, and deployed. That's a meaningful shift. Up until now, the regulatory landscape has been fragmented. FDA handles software as a medical device for certain diagnostic tools. There are some CMS reimbursement signals. But a coherent federal framework for clinical AI broadly? That hasn't existed. This is the beginning of that.
And the timing matters. We're not talking about a future in which hospitals might deploy AI. They already have.
Right. And that's precisely what makes this uncomfortable. If HHS had convened this group in 2022, we'd be writing prospective rules for prospective tools. Instead, we're writing rules that will be applied, retroactively in effect, to tools already running inside clinical workflows. That's a very different problem.
So the standards arrive after the deployment wave. What categories of tools are we actually talking about?
3 big buckets. First, clinical documentation AI. Ambient scribes, summarization tools, things like the Lapsy Health and Redox integration announced this week, where clinical AI is being piped directly into EHR systems to surface insights. Second, diagnostic aids, imaging algorithms, sepsis predictors, early warning systems. Third, care management algorithms, and Cigna's announcement about expanding their AI-enabled care management program, projecting $200 million in savings, is a live example of that third category operating at scale right now.
$200 million in projected savings gets a CFO's attention fast.
It does. And I want to sit with that number, because projected savings is a financial metric. It's not a clinical outcomes metric. Those aren't the same thing. And the difference between them is going to be central to whatever HHS produces.
Okay, let's go clinical. From a physician's standpoint, the question I always have is, does this actually touch care? And how?
It touches care in all 3 categories, but with very different evidence bases. Documentation AI. The argument is that by reducing documentation burden, you free physician cognitive capacity, which improves clinical decision-making and reduces burnout. That's a plausible mechanistic story, but do we have prospective, controlled evidence that ambient scribing reduces diagnostic errors or adverse events? Not robustly. Not yet.
But we have evidence on burnout reduction, don't we? Physician satisfaction, time savings.
We have survey data and time motion studies. Those are proxies. They're not the same as showing the downstream clinical outcome. The patient is better off. I'm not saying the tools are harmful. I'm saying the evidence chain is incomplete, and that matters when a federal body is about to ask you to produce it.
That's the gap you keep returning to. Performance metrics versus clinical outcomes. Say more, because I think a lot of leaders hear 90% accuracy and think that's the evidence.
This is so important. Accuracy, sensitivity, specificity, those are model performance metrics. They tell you how well an algorithm performs against a labeled dataset, usually retrospective, often from the institution that built the tool. What they don't tell you is whether deploying that tool in a real clinical environment, with real workflow integration, real alert fatigue, real population variation, whether that deployment actually changes what happens to patients. Reduced mortality, fewer adverse events, better equity across demographic groups. Most deployed clinical AI has demonstrated the former, but not the latter.
Give me a concrete example where that gap has actually shown up.
Sepsis prediction algorithms. Several major health systems deployed early warning algorithms with impressive AUROC scores, area under the curve, a model performance metric. When independent researchers studied patient outcomes at institutions running those algorithms, the results were mixed at best. Some studies found no significant reduction in sepsis mortality. One analysis found the alert burden actually contributed to alarm fatigue, which has its own patient safety implications. The model performed well against training data. The clinical outcome evidence was far weaker. And that tool has been running in hospitals for years.
So when HHS writes these standards, the question isn't just, does your AI work? It's work by what measure, in what population, validated by whom?
Exactly. And I'd add, validated when? Clinical populations drift. A model trained on data from 2020 may not perform the same way on a population in 2026. Data drift is real, and most health systems don't have systematic monitoring in place to detect it.
Hold on, I want to push back on that, because I think you're describing a standard that may not be achievable. We don't hold every clinical protocol to a randomized controlled trial. We use clinical judgment, observational data, expert consensus. Why should AI be held to a higher bar?
I'd actually flip that. I think we should be asking whether we hold clinical protocols to a high enough bar, and the history of medical practice suggests we often haven't. But more directly, clinical AI is different from clinical judgment in one critical way. It scales instantly. A physician's flawed heuristic affects the patients in front of that physician. A flawed algorithm deployed across a 50-hospital system affects every patient it touches, simultaneously, at scale. The risk profile is categorically different.
Okay, but here's where I think that argument runs into trouble. If you set the evidentiary bar at prospective, externally validated, outcomes-level evidence before deployment, you're not just slowing down bad tools, you're slowing down tools that are probably net beneficial. There's a real cost to overcaution, and I don't think you fully accounted for it.
That's fair, and I don't want to dismiss it. But I'd push back on the framing. The choice isn't between deploy freely and wait for a perfect RCT. There's a middle ground, pre-deployment validation on representative data, a post-deployment monitoring plan, defined performance thresholds, equity disaggregation. That's achievable. That's not a moratorium. What's not defensible is deploying a tool, calling it validated because it has a good AUC on an internal data set, and then being unable to answer a federal regulator's questions about clinical outcomes 2 years later.
What about the argument that documentation AI specifically is low enough risk that the evidentiary bar should be calibrated accordingly?
That's a reasonable framework. And I expect HHS will use something like it. Tiered standards based on clinical risk. The problem is that low risk can be a label that gets applied too liberally. There are documentation tools that surface clinical insights, flag potential diagnoses, recommend next steps. At what point does a documentation tool become a diagnostic aid? That boundary is blurrier than vendors often represent it.
And that blurriness is going to be a negotiation between industry and HHS about where the lines get drawn.
Which is why health system leaders need to be in that conversation, not just receiving the output of it. The people most fluent in how these tools actually behave inside clinical workflows are the clinicians and operational leaders inside health systems. If they're not engaged in the standards writing process, the standards will be written by people who understand regulatory theory, but may not understand operational reality.
I want to bring in the Cigna example again, because I think it illustrates a different dimension. Their AI care management program, $200 million in projected savings, focused on complex patients. From a payer's perspective, compelling story. But what's the clinical evidence underneath it?
That's exactly the right question. And I don't have visibility into Cigna's internal validation data. What I can say is that care management algorithms for complex patients have a complicated history. Early evidence suggests some have improved care coordination and reduced avoidable hospitalizations. But others, and there is published literature on this, have encoded racial and socioeconomic bias because they use cost as a proxy for health need. A patient who has historically had less access to care has lower historical costs, so the algorithm under-identifies them as high need. That's a real, documented problem. Whether Cigna's specific program has addressed it, I genuinely don't know. But it's the question I'd ask.
And the equity dimension, does it show up in what HHS is likely to prioritize?
It should. The Biden-era executive order on AI had equity and bias testing as explicit requirements for health AI. Whether the current administration's HHS carries that forward with the same emphasis, that's an open question. And I think health system leaders should watch it carefully, because if federal standards don't mandate equity testing, that doesn't mean the liability exposure goes away. It just means the pressure comes from a different direction: litigation, state regulators, advocacy organizations.
Let me get to implementation reality, because this is where the conversation gets genuinely difficult for the people listening. You've got a health system leader, a dozen AI tools in production, documentation AI, a deterioration index, a care gap identification tool for value-based contracts. HHS is now writing standards. What does Monday actually look like?
Monday looks like a very uncomfortable inventory exercise. For every deployed AI tool that touches clinical decision-making, you need 3 things. What evidence was the tool validated on? Who conducted that validation? And has it been monitored for performance drift since deployment? My strong prediction is that for a significant fraction of deployed tools, the honest answer to at least one of those questions is, we don't know, or not rigorously.
I think you're right. And I want to name the political difficulty inside health systems, because it's real. Some of these tools were championed by the CMO, or the CMIO, or a specific department chief. Asking hard evidentiary questions about them isn't a neutral act.
No, it's not. And that's one of the structural problems with health system AI governance right now. The people responsible for deploying the tools are often the same people responsible for evaluating them. That's a conflict of interest. Independent review of deployed AI, not just pre-deployment validation, but ongoing post-market surveillance. That's what a serious governance structure looks like. Very few health systems have it.
But I want to push back on you here, because I think there's a version of this conversation that becomes paralyzing. If the standard is prospective, externally validated, outcomes-level evidence for every deployed tool. Some tools that are probably net beneficial get pulled or stalled. And you're asking health system leaders to do this inventory with the same stretched teams that are already managing everything else. That's not a small ask.
It's not. But I'd reframe it. The inventory isn't optional anymore. The question is whether you do it on your own terms now or on a regulator's terms later. And doing it on your own terms means you can prioritize. You don't have to validate everything at once. You stratify by risk and evidence quality, and you focus your limited resources on the tools where the gap is largest and the clinical stakes are highest. That's manageable. What's not manageable is being handed a federal audit with no prior work done.
Okay, walk me through that stratification because I think that's where the practical value is.
So you'll likely find 3 tiers. First, tools with reasonable evidence operating in a monitored environment. Those are fine. Continue them. Second, tools with moderate evidence gaps but low clinical risk. You can probably keep those running with enhanced monitoring and a plan to close the gap. Third, and this is the uncomfortable tier, tools with significant evidence gaps and meaningful clinical risk. Those need immediate attention, either a pause, an accelerated internal validation study, or a very honest conversation with the vendor about what evidence they can actually produce.
That conversation with the vendor, I want to flag that as genuinely difficult. Vendor contracts often don't require the vendor to produce ongoing outcome evidence. The health system accepted the tool based on a validation study the vendor provided, and there's no contractual mechanism to compel updated evidence.
Correct. And it's a contracting failure that health systems need to start correcting going forward. New AI contracts should include explicit requirements for ongoing performance monitoring, demographic performance disaggregation, meaning you can see how the tool performs across race, age, sex, insurance status, and a right to audit or exit if the tool fails to meet agreed performance thresholds. Very few contracts written in the last 3 years include all of those provisions.
Now, here's where I want to push back on you again, because you've recommended that health system leaders engage in the standards process. But health systems engaging in that process also have an interest in standards that aren't too stringent, because stringent standards might require them to pull tools they've invested in. That's a conflict of interest too, and I'm not sure you've fully reckoned with it.
You're right that the conflict exists. I don't think engagement is therefore wrong. I think it has to be honest engagement. Health systems should be advocating for standards that are operationally grounded, not standards that are operationally convenient. Those are different things. A standard requiring prospective RCT evidence for every tool before deployment isn't realistic. A standard requiring pre-deployment validation on representative data, plus a post-deployment monitoring plan with defined thresholds, that's achievable and clinically meaningful. Health systems can push for the latter, but they have to be honest about which argument they're making and why.
Let me ask you the harder version of your own question, the one you said most leaders are dreading. If HHS asked your health system today to produce the clinical evidence supporting every deployed AI tool, how many could pass? What's your honest estimate?
Fewer than half, maybe significantly fewer. And I want to be careful. Pass the test depends on what the test is. If it's a solid internal validation study on a reasonably representative dataset with some post-deployment monitoring, maybe half to 2/3 pass. If it's externally validated, prospective, outcomes-level evidence with demographic disaggregation, I'd be surprised if 20% of currently deployed tools could meet that bar. I'm not certain of that number. It could be higher if health systems have done more rigorous work than I'm aware of, but I'm confident the gap is real and significant.
20%. I want to sit with that, because it suggests the gap between what's deployed and what the standards might require is enormous. But here's what I'd push back on. You're applying a standard that doesn't exist yet. You're grading health systems against rules that haven't been written. Isn't that a little unfair?
I'd say it's the opposite of unfair. The evidentiary principles I'm describing aren't new. They're the same principles that have governed evidence-based medicine for decades. The fact that health systems deployed AI without applying those principles isn't a defense. It's the problem. And when the standards do arrive, we didn't know the rules yet is not going to be a compelling argument to a regulator or a plaintiff's attorney.
That last part, the plaintiff's attorney. I think that's what will actually move the needle for health system boards.
Probably. Which is a little depressing, honestly. I'd prefer the motivation to be patient safety, but I'll take accountability from whatever direction it comes.
There's something I want to name explicitly: the equity piece, because it can get lost in the governance conversation. If a tool performs well on average, but differently across racial or socioeconomic groups, and you don't know that because you never disaggregated the performance data, that's a patient safety problem happening right now, not a future risk.
Yes, and it's also a regulatory risk, a litigation risk, and a reputational risk. But primarily, yes, it's a patient safety problem. And the uncomfortable reality is that most health systems don't have the internal infrastructure to do that analysis themselves. They depend on vendors to provide disaggregated performance data, and most vendors don't provide it proactively. So health systems are in the position of not knowing what they don't know. And I'd push back on the framing that this is just a vendor problem. Health systems have the contractual leverage to demand this data. Most haven't used it.
That's a fair challenge. We've been somewhat passive on the demand side.
Very passive. And that passivity is going to look worse in retrospect than it does right now.
Let me ask about forward signals, because I think there are a few things our listeners should have on their radar. What are you tracking in the next 6 to 12 months?
3 things. First, the specific evidentiary framework that comes out of this HHS process. The devil will be in the details. Are they requiring pre-deployment validation, post-deployment monitoring, equity testing? Each has very different operational implications. The framework document, when it comes, needs to be read carefully by clinical and operational leaders, not just the compliance team.
And you're worried the compliance team will read it as a checklist rather than a clinical question?
Exactly. Compliance teams are good at checklists. They're not always equipped to ask whether the checklist actually maps to patient safety. That translation has to happen at the clinical leadership level.
Second signal?
Watch what happens with FDA's software as a medical device pathway as it interacts with whatever HHS produces. Right now, there's potential overlap and potential conflict between those two regulatory tracks. If HHS standards apply to tools that FDA has already cleared, or vice versa, health systems could find themselves navigating two sets of requirements that don't fully align. That hasn't been sorted out, and it needs to be.
And third?
The litigation landscape. The first significant malpractice case where an AI tool's failure is central to the claim, and I believe that case is coming, if it hasn't already been filed, will do more to change health system behavior than any number of federal standards, because it will answer the question every risk manager is quietly asking: what is our liability exposure if an AI tool we deployed, without rigorous evidence, contributes to patient harm? That question doesn't have a clear legal answer yet. When it does, the landscape will shift fast.
And I'd add a fourth signal because I think it's underappreciated. Watch what happens to the tools that can demonstrate outcomes-level evidence. If a handful of vendors can show up with genuine clinical outcome data, demographic disaggregation, and post-deployment monitoring records, they're going to have a significant competitive advantage over vendors who can't. The standards process doesn't just create compliance risk, it creates market differentiation. And health systems that have demanded that evidence from vendors are going to be in a much better position than those that haven't.
That's a good point. Though I'd add a caution. Outcomes-level evidence can be manufactured if the incentives are wrong. Industry-sponsored studies, selective reporting, endpoints chosen to show the tool in the best light. Health systems need to be sophisticated consumers of that evidence, not just recipients of it. The fact that a vendor can produce a study doesn't mean the study is good.
Which brings us back to the internal capability question. Health systems need people who can actually evaluate that evidence, not just receive it.
Right, and most don't have enough of them. Clinical informatics teams are stretched. The people who could do rigorous evidence evaluation are often the same people managing the deployment and the vendor relationships. That's a structural problem that doesn't get solved by a governance policy. It gets solved by investment in people. And that investment is hard to justify when the tools are supposedly saving money.
That's the tension that I don't think we can resolve today, the resource question. You're describing a level of internal capability that requires real investment at a moment when health systems are under significant financial pressure. And the tools are being sold partly on the promise of reducing costs. So you're asking health systems to spend money to rigorously evaluate tools that are supposed to save them money. That's a hard sell.
It is, and I won't pretend it isn't. But I'd frame it this way. The cost of not doing it is not zero. It's just deferred. The cost shows up when a tool fails, when a regulator asks questions you can't answer, when a plaintiff's attorney finds out you deployed an algorithm without adequate evidence and something went wrong. Those costs are real. They're just not on this year's budget.
That's the argument that might actually land in a boardroom, the deferred cost framing.
I hope so, because the patient safety argument, which is the right argument, often doesn't move fast enough. The financial risk argument tends to move faster. I'll take the faster one if it gets health systems to the right place.
Professor Harris, one last question. If you had 60 seconds with a hospital CEO in an elevator, what's the one thing you'd say?
Stop treating AI governance as a future problem. The tools are running now. The standards are being written now. The liability is accumulating now. The question isn't whether you should have a governance structure for clinical AI. You should, and if you don't, you're already behind. The question is whether the governance structure you build is built around actual clinical evidence or around the appearance of rigor. Those are very different things. And eventually, through regulation, through litigation, or through a patient safety event, the difference will become visible. You want to be the health system that can demonstrate the former, not the one scrambling to explain the latter.
That's a challenge that will sit with our listeners for a while, as it should. Professor Harris, thank you for slowing this conversation down in exactly the ways it needed to be slowed down. Genuinely uncomfortable, and I mean that as a compliment.
I'll take it. Thank you for having me.
Let me bring this together before we close. What we covered today is a genuine inflection point. HHS is not studying clinical AI anymore. They're writing the rules. And those rules will be applied to tools already running inside your health system, touching clinical decisions right now. The central tension we kept returning to is this. The evidence base from many deployed clinical AI tools is weaker than most health system leaders realize. And the gap between performance metrics and clinical outcomes is real and consequential. That's not a reason to panic, it's a reason to act. Specifically, to do the inventory, to stratify by risk and evidence quality, and to engage in the standards process so that what gets written is both rigorous and operationally grounded. What we couldn't resolve today, and I want to be honest about this, is the liability question. When an AI tool contributes to an adverse outcome, who is responsible? And what evidence of responsible governance protects a health system? That question is live, it's unsettled, and it deserves your attention. before it's answered in a courtroom rather than a boardroom. And the resource question, how health systems build the internal capability to do this rigorously under financial pressure with stretched teams, that's also unresolved. Those are the tensions you're going to have to sit with. If this conversation was useful, and I genuinely hope it was, please subscribe to Agents of Health so you don't miss an episode. These are the conversations that are shaping the decisions you're going to have to make, and I want to make sure you have them before the decisions land on your desk. If this episode made you think, or made you uncomfortable, or made you want to check what AI tools are actually running in your own health system, please like it and share it with a colleague who is wrestling with the same questions. The CMO who championed your documentation AI, the CMIO who owns your deterioration index, the CFO who is eyeing that 200 million savings projection, they need this conversation too. And I want to hear from you. Leave a comment with your questions, your disagreements, your real-world experiences. If your health system has done the inventory and found something surprising, I want to know. If you think Professor Harris is setting an impossibly high bar, make that case. If you've seen an AI tool actually move the needle on clinical outcomes with the evidence to back it up, please share it, because that's the kind of signal this community needs. I read the comments, and I may feature your questions in a future episode. This conversation is too important to be one-directional. Thanks for listening to Agents of Health.